I'm Mayor Bill McLeod, and Jennifer Georgievic, the Director of Operations and Outreach for the Mayor and the Board as trustees are with me here. We're at the Amita Health and Vascular Institute, and we're going to talk to a leading cardiologist, Dr. Saba Khan. We're going to meet with her in the cath lab, so I get to ask her what a cath lab is. This month, February, is Heart Health Month, and this is another episode of Heart of Hoffman Estates. So come on in with me and let's meet Dr. Khan. Very fortunate to be here with Dr. Saba Khan, who's a cardiologist at St. Alexius Medical Center and the Women's and Children's Hospital, and we're in the cath lab. Doctor, what is a cath lab?
The cath lab is a place where we bring all our patients who are having heart attacks. It's a minimally invasive way to fix the blockages in the heart. It is not only done just for heart attacks, but also all kinds of blockages, whether it's your blockage in your neck, whether there's a blockage in your belly, or blockages in the leg. So up in 1980s, around that time, we started developing, actually perfecting angioplasty, which is a way of going through the main artery in your leg. We go all the way to your heart, shoot dye and take pictures. This is the X-ray machine which is almost a live way. All you see is the arteries of the heart. As you can see, this artery is nice, beautiful, and smooth, whereas here you can see a haziness. This haziness is in the main artery that runs in the front of the heart, and that can cause blockages. This blockages, sometimes this person is still lucky because you can see the blood flowing all the way down, but in a major heart attack, what we call the widowmaker, which happens in this artery gets 100% closed off.
What happens in a heart attack, and how do you help?
So there are two kinds of blockages that happen. One is the slowly growing blockages that happen over time. All blockages in a human heart or any part of the body are made up of cholesterol plaques, which then follows with calcium. And your body's response to any plaque is to heal it by depositing small layers. There's a constant inflammation that goes on that causes blockages. So these blockages can develop over time. It's interesting that they've done studies that show that blockages can happen as early as the first decade of life. That means a 10-year-old child can start developing blockages at that point. So when these blockages happen, when they slowly develop over time, what we hear in everybody talking about angina, which is basically chest pain or pressure or tightness or squeezing sensation, or maybe just a simple discomfort that happens when a patient is walking. Usually happens when you're exerting yourself. Sometimes as the disease progresses further, at 75% you may have symptoms. At 90% you will have symptoms at rest. Whereas heart attacks, on the other hand, do not necessarily happen in these 90% blockages. They can happen in 20, 30, usually 30 to 50% blockages. These are what we call the vulnerable blockages. That means it's full of cholesterol. The blockage is nothing but cholesterol, and a little cap on the blockage tears. The cholesterol goes into your bloodstream. Your body's natural response is to heal it by forming a clot. What does the clot do? Closes off the entire artery. So you may have a person just had the stress test done 2 weeks ago, completely normal, but may have risk factors of heart attack or heart disease, and they will come with sudden onset of chest pain. It's usually pain, pressure, tightness. Anyway, I say to all my patients, your symptoms can be just in the jaw, with some associated shortness of breath, with some nausea, vomiting, sweating. You may just feel fatigued or tired. Listen to your body. Do not think this is indigestion or heartburn if you have a burning sensation. Always listen to your body.
In terms of symptoms, Dr. Khan, what are some of the differences between men and women when they're experiencing a heart attack?
I'm so glad you asked that question, because there is subtle differences between men and women. First of all, men usually present early on when they have a heart attack. The disease is considered the disease of men, but no, it's not true. 1 in 4 women will die of heart or cardiovascular disease. Based on the most recent statistics, there are about 300,000 deaths attributed to heart disease in patients. So how is it different? How is this heart disease different in men versus women? Most importantly, the symptoms. Women are older when they present. So you're protected up until you're menstruating till the age of 55 or 45 in that period. But once you stop menstruating, within 10 years, your risk of heart disease or heart attack doubles. And most people are not aware of that. And second thing is, when they do have a heart attack, they may not have the classic crushing chest pain. They may just feel fatigued and tired with a jaw discomfort, or tightness in the back, or burning sensation in the throat, or just feeling short of breath, not being able to move around and fatigued. And as you know, we are women, right? We are supposed to take care of the rest of the world and last ourselves. So we are like, oh, this is just heartburn. So they tend to come later to the hospital when they have, whereas when a man has anything in his chest from here to here, first thing he thinks, oh my God, I may be having a heart attack. Whereas the woman says, oh, this is just heartburn, I'm going to take. So they come later. Because they come later, they're not treated as efficiently as fast, because heart muscle dies without heart attack, without blood in it, and that will never recover. So the longer they come or the later they come, the less chances of saving the heart muscle. They will survive it. We will definitely open up the artery and restore blood flow. But the key is to avoid maximal damage. The key is to get to the patient within 90 minutes of having a heart attack and open up the artery, because heart muscles doesn't die up to 3 hours. So the sooner we get to these patients, the sooner they come, and being aware of these symptoms is more important. Being aware that heart disease is the #1 killer in women. Breast cancer affects women. Yes, 1 in 8 women will have breast cancer, but remember, 1 in 4 women will die from cardiovascular disease, heart or vascular disease.
Those are stunning statistics that I had no clue about. So you often hear sometimes they'll have a stroke, and then they'll find out, well, earlier they'd had a heart attack. So you say listen to your body, but at what point should someone say, well, maybe this isn't acid indigestion, maybe it's just not shortness of breath, maybe I've actually having a heart attack? What do you do?
So that's a very good question again, because what happens is, in these patients, most of the silent heart attacks that come later are seen in diabetics. These are the people who do not have classic chest pain. They may just have chest tightness or heaviness. When you have symptoms that persist beyond your regular heartburn, you take your Tums, you do something else, but it keeps coming. That's your first clue or first sign to pick up the phone, call your doctor. And more importantly, in all these patients, it's about preventing these diseases, identifying who is really at risk, who is going to have the highest likelihood of having a heart attack or stroke or dying in the next 10 years. Finding these high-risk patients and trying to help them before they progress into heart attacks and heart disease.
What are the risk factors that people can keep an eye out for, and are there different risk factors for men versus women?
There are 2 kinds of risk factors I always tell my patients. Your modifiable one, that means you can change those. The non-modifiable ones, your family history, your genetics. You cannot change your genes, but you can change what you eat, how you take care of your body, and whether or not you exercise. So by genetics, I mean if you have a strong family history. By that, if you have a brother or a father who's had a heart attack or heart disease under the age of 55, or a mother or a sister who's had heart attack or heart disease under the age of 65, that is considered 1 negative. Family history is positive. And as we know, many people that we know, we turn around and look, each one is probably positive right now. So family history is very, very important. The other risk factors is presence of high blood pressure, important risk factor. Obesity, very important risk factor. Diabetes, which usually results from obesity or your genetics again. Smoking, very big risk factor. In fact, last night I was on call, and this young gentleman who was younger than me, he had family history, smoking. That's it. He came in with the widowmaker with a 99% clot in his main artery right here. He's doing really well. We got to him immediately. He had his symptoms at 10. By 11:30, we had opened up his artery as soon as he came to the hospital.
So I guess that invites the other question: what should somebody do if they are having heart attack symptoms? Do they call 911 or do they drive themselves to the hospital?
Call 911. Always call 911 because at least based on the old statistics, 33% of the people having a real heart attack, a massive heart attack, may not even make it to the hospital. Having EMS specialties, having what we call treatment in the field. What we have now at St. Alexius, Alexian, and majority of the hospitals here, they do an EKG, they transmit it right away. So even before the patient hits the emergency room, there's a team waiting, ready for them to go into action. And what we call is a cardiac alert. Basically, there are 6 different things that go in motion when a person is having a heart attack. The ER physician, the nursing team, the cath lab team, the interventional cardiologists all get mobilized. And we all are here within 30 minutes. The patient is here on the table getting his heart fixed within 30 minutes.
That's great because most communities around here have paramedics. Every firefighter is a paramedic, and they're in contact with the hospital, and they're getting advice from the hospital after the EKG of what drugs to administer, what they should do. It's amazing.
It is, and everything happens fast, like really fast, and those are life-saving measures. Having an AED is a life-saving measure again, no?
What are some additional services that you would provide here within the Heart and Vascular Institute in addition to serving those immediate needs?
You know, we have come a long way when it comes to cardiovascular diseases. We really have. We have gone from just being bypass surgery to minimally invasive, where the patient goes home within 24 to 48 hours after having a heart attack. So things have really changed. But what is still sad is it's still the #1 killer. It is. Cardiovascular diseases is the #1 killer in the United States and in the world. What can we do, or how do we change these modifiable risk factors, I call it, like being aware of what your risk profile is and seeking help? Any person over the age of 40 should have an EKG, should have a cholesterol panel. Any person who's had a family history of heart disease, you should start getting screened 10 years prior to your siblings or father's event. Suppose your father had a heart attack at the age of 50. You should start getting aggressive screening at the age of 40. And by screening, I mean a simple blood test that looks at the whole cholesterol panel. Sometimes people just focus on total cholesterol. Oh, my cholesterol is great. It's not the total cholesterol. The cholesterol has 3 components to it. What we call LDL, I teach my patients, L for low. That is your bad cholesterol. HDL, H for high, that's your good cholesterol. So you need to focus on these numbers, okay? And be aware of it. Just being aware of it makes the first step about identifying, okay, my LDL is bad. I need to focus on what I eat, how I exercise. Second thing is we have another more novel screening patterns that beyond cholesterol. In person who has a strong family history, we have specialized blood tests that we do. That is not just the cholesterol panel, which is called ApoB. We have high sensitivity cardioprotein, CRP. Those are the tests we do to identify inflammation in the body. So if those tests are high, then we aggressively move forward. So a normal person without any risk factor, your LDL goal should be less than 160. Whereas a person who's got more than 2 risk factors, your LDL goal, your bad cholesterol, should be less than 100. So we treat these patients differently. We absolutely focus more aggressively in avoiding a heart attack. Taking a baby aspirin in any person who's got risk factor after the age of 50, especially in a man. In women, we still have combined data about it. Then the more important thing which we do also at St. Alexius and Alexian Medical Center is calcium scoring. Calcium scoring goes beyond cholesterol. Wherever there is plaque buildup, there's calcium buildup. So it's a simple test that is offered for $99. Even if your insurance is not covered, it's a very good $99 spent for the next 5 years in your bank kind of thing. And we look at the amount of calcium buildup and then divide you into different risks, which Dr. Sauri later will go over. Today we're going to discuss about not just prevention of heart disease, but what are the different imaging modalities we have at Amita Heart and Vascular Institute. Here with me is Dr. Daniel Sari, who's the Director of Cardiac Imaging. We provide services with 256 slice CT scanners, cardiac MRI, and more importantly, calcium score to identify high-risk patients with coronary heart disease. Dr. Daniel Sari is going to explain these tests and how it will better risk stratify patients and help communities prevent heart disease. Here's Dr. Daniel Sari.
Thank you. Well, I wanted to talk a little bit about coronary calcium score to begin with. Coronary calcium score is a CT scan that we do in order to figure out whether you have plaque or not in your heart arteries. We know that plaque is the big determinant of whether you're going to have a heart attack or not. And while a stress test can tell us that you have critical plaque or severe plaque, it doesn't tell us if you have plaque building up so that we can intervene upon it with medication and lifestyle changes before it becomes a heart attack or a problem. So here at Amita Heart and Vascular Institute, we're very much into prevention and preventing the problem before it actually occurs. So to show you in terms of the calcium score, I have this up on the screen here. And we can say that this is a patient that we have put into our CT scanner. They required no contrast and they required no IV. And we were able to obtain images of their heart. First, you can see the heart here, just straight on. And then you can actually slice the heart up and down. And you can kind of see this being the heart muscle. We can actually see within the heart arteries if there's plaque or no plaque. The heart arteries run along the borders of the heart here. And here you can actually see that there is some calcified plaque here. And this plaque puts patients at higher risk for having a heart attack long term. So our goal with the calcium score is to identify those patients who have quite a bit of plaque, grade and quantify how much plaque they have, and then be able to provide them with a risk score in terms of what their risk of having a heart attack would be over the next 10 years. This is a great way to be able to decide with your doctors how aggressive you need to be in terms of prevention, such as high blood pressure, diabetes control, and how aggressive to be with cholesterol and statin medicines. So this provides us with a look inside your heart, and it really tries to identify those patients who are going to be at higher risk, and we need to work with them on a larger strategy overall. So the amount of plaque that we just saw tells us that the patient is at risk for a heart attack, that their risk would probably be about 2 times as much as a person their age and gender for the next 10 years. And because of that, it allows us to say that that patient will likely need more intensive medical therapy in order to try to provide a way to reduce the risk of heart attack and also stroke. A second type of testing that we perform is called CT angiography. This is a non-invasive test that looks at your heart arteries directly. We're used to looking at angiograms, and people have had those for many years, but that's an invasive procedure. And CT angiography allows us to do it non-invasively without having to put any catheters and such in the body. It gives us a very beautiful picture of the heart arteries and allows us to see if there actually is any plaque that's building up or causing any critical stenosis. So this is an example here of one of our CT angiograms that we obtained on our 256 slice scanner. The 256 slice scanner is actually state-of-the-art and actually is a machine that is not owned by many hospitals here in the area. And so we've had the wonderful opportunity to work with it now for the last few years and have shown it to be very accurate in terms of predicting heart artery disease and critical blockages. If you look here on the scan, you see here a person who has one of their arteries called the left anterior descending artery. And what you see is fairly normal artery, which then has a narrowing. The narrowing becomes very critically stenosed here at this point in time. There's both calcified plaque, which is white, and then soft plaque, which is the darker shading that we see. And this actually demonstrates to us that there is a very severe stenosis in the first part of the left anterior descending artery. And a blockage in the first part of the left anterior descending artery is what we call the widowmaker. This is something that's very important to identify, and by using our technologies we were able to identify this in the patient and treat it appropriately with stenting. So for CT angiography, this gives us, again, a wonderful picture of the heart arteries, and it gives us more detail than a regular stress test would. The stress test can tell us whether there's critical blockages, but there are false positives in terms of stress tests. When people continue to have discomfort or symptoms, we then go to CT angiography to try to see if there actually is something more than what we can see on a stress test. In this example, we see that there actually was a blockage that was fairly critical, and almost 90% here in the first part of the left anterior descending artery, which we call the widowmaker. So this is a good example of how CT angiography is able to provide more information than traditional testing for the heart, and gives us an idea of really whether you're at risk for a heart attack or not. So this would give us an idea also of problems, that plaque that's building up in the heart arteries that people may not be aware of, and would allow us to change our treatments so that we could prevent the problem from occurring in the first place. The CT angiogram also helps us with not only blockages in the heart arteries, but also blockages in the legs and in the carotid arteries, and really allows our interventional team to plan on how to correct the problem from the beginning. You see an example here of a CT angiogram that is of the leg arteries. And what we see actually here is that on the left side, we see a very critical blockage here of the leg arteries that is greater than 80% narrowing. The patient was having symptoms of leg pain when walking, and by correcting this area of blockage, the patient will have a resolution of their symptoms of leg discomfort when they walk. So this demonstrates how this technology not only helps for the heart, but the entire vascular system overall, and we really use it from head to toe. So this technology also allows us to pinpoint areas where the problem is, and so when our interventionalists go in to take a look, they know exactly what areas to attack and correct so that the patient can have relief of symptoms immediately. So calcium scoring, again, is a technology that allows us to predict the risk of having a heart attack. Any physician can order this exam, and it's particularly useful in people who don't have any known history of heart disease but would like to have a better understanding of what their risk is. It helps plan in terms of medications and what needs to be done in order to prevent further problems, in order to prevent also heart attacks and strokes.